starting to want to commit these to memory, like the force of the stream of urine. I mean, that's something I just didn't automatically think to ask when I was a student. The things like frequency, urgency, hesitancy. Does everybody know what hesitancy means? Hesitancy to get the flow of the urine started. It's hesitant when somebody tries to start to pee. So everybody can figure out frequency, everybody can figure out urgency. Blood in the urine, urinating at nighttime, dysuria is pain with urination. Any questions about these? When you talk about incontinence, you can ask specifically, do you have overflow of urine when you just really have to go, like you held it for a really long time and it's now down to urgent emergency and then I have incontinence, or is it incontinence when I cough? So again, today's lecture is mostly focused on the male patient. So these are things you want to ask them about for your review of systems. Discharge from the penis, lesions, testicular pain, testicular masses. Swelling is, considered like a mass, just a mass of swelling. Whether they've ever had an inguinal hernia, because if you've had an inguinal hernia, you're at higher risk for another one on the opposite side. So ask your male patients if they do self-testicular exams. Most men, only got one guy in here. Most men touch their junk a lot, so most of them have belt around, and they'll just tell you, no, I don't do self-testicular exams, but I mean, I touch them a lot. So just ask if you felt anything abnormal. Sexual dysfunctions can be a bit embarrassing for younger male patients. Older men, they become a lot more open as they get older, but they'll have a very difficult time putting into words what they want to try to tell you. So just try to shoot straight with them. Are you having a hard time getting an erection, or are you having a hard time keeping an erection? Is your erection not lasting long enough? Just try to get past the being embarrassed or fear of embarrassing your patient. Just the more you just get it out and directly ask, the better off it's going to be for everybody. If you kind of tiptoe around subjects, they're going to get more uncomfortable. So the straighter you shoot, the quicker to the point you get, the better it is for everybody. These medical history things, a lot of them to me are just pretty self-explanatory. Your sexual history comes much more into play with a review system and for a urinary complaint. You always want to ask if they have a urinary complaint, which might sound like an infection or something. Ask if they've had any congenital problems, any family history of congenital urinary problems, if they've just had a catheter taken out. Things like that, whether they're circumcised or uncircumcised, is important as well. You'll see a lot more urinary infections in diabetic patients. So diabetes is very important for these patients past menopause. And again, some things in the family history. Renal cell, Professor Brooks, renal cell runs in the family, I think, but bladder does not. Is that, yeah.
Renal cell carcinoma, and there's an interesting story. We'll give a lecture on this next, just later this week, but I had a friend, he this whole time he thought he was a Roberts. Okay, so he did that 23andMe. He'd gotten renal cell cancer like last year. He had no family history of it, didn't know why he got it. Come to find out after he did that meeting 23, he's actually not a Robert. His mom had an affair between his dad, and so he found his real dad. His real father had renal cell carcinoma, and so did his uncle. So it is familial. He actually ran into his family. But isn't that horrible? You go to just find out your lineages, you find out that isn't even your real father. They're both passed away now. His parents aren't living anymore. Isn't that crazy? But yes, that has to be.
Skeletons in the old closet. Have you done Ancestry.com or genealogy.com or don't argue with your elders about it. My husband and his father have just gone fisticuffs over, that ain't true. We have American Indian in our family history. There is none. Which if you saw my husband, it would be pretty obvious. You're like, you're straight from Ireland.
He has as much as Jimmy claims to have as well.
Right. It's like everybody that grew up in southwestern Oklahoma, and there's got to be some Indian in the family somewhere. Well, no, DNA doesn't lie. But that's a fight I don't want to get into about why you have renal cell carcinoma. Yeah, but bladder cancer does not. It's usually linked to smoking, so that's why I didn't list it in the family history. But renal cell is a big one, and then polycystic kidney, prostate cancer for sure. So again, smoking history. I mean, you guys have. It applies to everybody's system how important the smoking history is. But what gets to be a little bit more important as you get into urology is the sexual behaviors. You know, your sexual history, new partner, multiple partners, are you paying for sex? Are you using instrumentation of some kind? I think you've all heard the story of, well, you've met Dr. Hewson now, my neighbor, who had the story of the man who would stick the speaker wire into his penis. So you met Dr. Hewson, he gave you your electronic acute abdomen. So he has a recurrent patient who's been into the Shawnee ER more than once because he will take speaker wire out and thread it into his penis. You have, I mean, you shouldn't, these are things you should not have to ask people. But have you been sticking anything in your penis? It's some type of perversion that I do not understand. But he stuck a little bit too much and it just all got stuck, balled up into the bladder, and you had to operate on it to get it out. You couldn't pull it back out. So these kind of questions, you know, and you'll be surprised that you may not even have to ask a lot of questions. They'll just start telling you everything. You know? But if you have somebody that's a little bit more reserved, or a little more shy, or you just ask, you know, you'll be shocked at what you find out. Also, if they're a drug user, alcohol abuser, the use of intoxicating substances makes you a lot more likely to commit riskier sexual behavior. So just a quick, you know, drug and alcohol history, well, maybe that will sometimes lead you down another path for them to feel comfortable to tell you something else. So the importance of sexual history, you've been waiting now, here it is. You know, that's really important for urology and women's health. I put on there, do they wear adult diapers or depends? Because that, in the elderly people, that is a risk for urinary tract infection, because they'll, especially if they're in a nursing home that doesn't clean them or change them regularly, they'll just sit in basically a bath of E. coli all the time, and that puts them at pretty high risk of infection. Okay. So, what we already know about, you've already actually learned some of the steps for the GU exam. You want to, like we were just mentioning about angioedema or nephrotic syndrome, getting swollen face, periorbital edema, those are sometimes tied to kidney disease. Palpating a kidney is part of the abdominal exam. You're probably never going to palpate a kidney unless it has a mass on it. I mean, if you're feeling a kidney, that's abnormal. It's kind of like the spleen, and you would try to feel it in a very similar manner as you would a spleen. So just having your patient inhale and exhale, and try to just put enough counter pressure against the back, against the flank, so that when they breathe deeply in and out, you can feel it come down and touch your finger, similar to a spleen. But again, I've never palpated a kidney. Have you ever palpated a kidney?
No, and like Dr. Riley said, other than having an enlarged kidney from PKD or something like that, you should most likely never palpate a kidney.
You know where to palpate or percussed for CVA tinnitus already. Palpating the bladder is just part of the abdominal exam. If you feel a mass in the suprapubic area, it's either a bladder or a uterus. So if it's a man, probably a bladder, a distended bladder. And a female, if they have a uterus, it could be uterine enlargement as well. But how you kind of decide if it's uterine or bladder is if you press down on it and it kind of gives them that urge like they need to go to the bathroom to pee, that's probably a distended bladder you're feeling. So you can ask that question. And now, finally, what you've all been waiting for, examination of the male genitalia.
That's how you look at the picture that she ended up shooting. Yeah. Like Minetta talked about, the statue of David.
How, you know, great minds.
Yeah. Do you know how tall that statue is,
Is it 20 feet?
Close.
17.
Is he circumcised?
Couldn't tell you. Doesn't look like it.
That is like obsessed with how he's
I'm obsessed with the part in Goonies where they knock the statue off and then they break it. Has everybody seen Goonies? No. Yes. You never seen the Goonies?
Yes.
Oh my gosh, that's your homework.
I need
So
to
watch that this weekend. Well, they have a statue of similar to like the statue of David. It's like a replica, you know. And it's Sean Astin. They knock it off and they're like it breaks off that part, and he's like, "Oh my gosh, Mom's favorite part." Okay. So basically, when you're thinking about the male genitalia exam, you're going to want to kind of think of it in a three-part segment, 3 parts. You're going to examine the penis, you examine the scrotum and the contents in the scrotum, and you're going to examine the prostate gland. Now you're going to do hernia check as well, but we kind of talked about that already. We'll talk about it again in a minute. But the 3 main parts of the male genitalia exam are penis, scrotum, and its contents, and the prostate. So just some general guidelines for how, what, where, what do I do? Somebody tells me to do a general exam. You always want to have a chaperone. In today's time, I mean, even old school doctors, like old school male doctors, probably would not want a chaperone in the room if they were doing this exam on a male patient, but I would not do one without a chaperone in the room. Professor Brooks?
I remember, I was just thinking about this, when I was in PA school, on my rotation, I did an urgent care. I don't know how many hernia checks, but I was always the only female in there with the male. Because they're all male truck drivers, And I think back, I'm like, I could have gotten a little, but yeah, you should always do, even if it's a female, you do a pelvic exam, you most likely will always have your nurse with you. So I would always make sure someone's in there.
And it's not, and it's good, there's kind of security in numbers with you having somebody there, but then there's also a witness. It's hard, it sucks that you have to think about things that way, but a patient could step out and be like, your PA just molested me. And if you had nobody there to witness that exam, it's your word against his or
Or
hers.
if you don't remember to tell your patient, this is my hand, I'm getting ready to do your exam.
Yeah.
They may just say, well, she just touched me without telling me.
Right, so just always have a chaperone. I mean, in male or female, it really doesn't matter, especially in the way our culture is now with gender, these lines being obscured with gender anyways. Just another medical provider in the room is sufficient. Unless the patient tells you, because some patients with history of sexual trauma, or they will absolutely not want a man in the room, or vice versa. So if they specifically tell you they do not want a man in there, or a female, which I've never had that happen, but just respect those wishes, but try to always have somebody in the room with you. And if, let's say, all you have is a male nurse to assist you, and it's a female exam, and she says, I do not want a man in the room. If you can't get somebody else, then you just need to document it in your chart, you know, chaperone was offered, patient refused, and just thoroughly document what happened during the exam. Okay. And like Professor Brooks just said, don't surprise your patient. Tell them exactly what you're going to do, where you're going to put your hands, how you want them to position. Almost too much information is better, so you're not surprising them. Ask them, have you had your privates examined before? Yes or no. You know, say, okay, well, this is how the exam's going to go. So just being very forthcoming with information is going to break the ice a little bit and let it be a little bit more relaxed, as relaxed as it can be. Always avoid slang terms, sexually, I mean, that's common sense, sexually suggestive remarks, or, you know, no joking, no giggling, no laughing, things like that. Try to, even if you're extremely uncomfortable, don't break the ice by cracking a joke or something, you know. I mean, that is such a, you just have to kind of get a feel, literally and figuratively, for how your patient responds. Because I know my husband, the first time he ever had to get his prostate checked, because he thought he had prostatitis, or maybe his PA student wife thought he had prostatitis, I don't know. But he told the doctor, what, no foreplay? You know, like, you can't say things like that, you know. So just try, if somebody is very uncomfortable, like my husband's a jokester, he'll like say things like that to think it's gonna make everybody feel better. Yeah, just try not to just, you know, oh no, you know, I don't know how you respond to this. So washing your hands, obviously, using gloves.
That's what I would say.
Everybody should have gloves on their hands. But the male genitalia exam should be done with the patient standing. That's because varicoceles, masses, hernias, things will bulge and, you know, show themselves with the patient standing with gravity versus laying down. So you always want to do the exam with the patient standing up. Don't forget to look at the other side of things. So, you know, girls, lift it up, look underneath, you know, move things around. If you retract the foreskin, make sure you put it back where you found it. Don't forget to kind of look around for lesions and within the pubic hair and things like that. Never examined anybody that I actually saw nits on, but I'm sure it's possible. Everybody knows what nits are, right? Maybe you itch for the rest of the day. So first we'll go over the penis. So do you pronounce it prepuce? I don't know.
Prepuce.
Prepuce?
Prepuce.
I don't know who says this. I say foreskin. But you cannot examine the penis without retracting the foreskin. So if it is an uncircumcised patient, you have to pull that hood of skin back so you can see the glands. So the glands sits underneath the foreskin. You do want to note if there's difficulty retracting it, because it shouldn't be. The foreskin should pull back very easily without any resistance. So if there's difficulty retracting it, that's pathologic in and of itself. Who knows what smegma is? So the white, like cheesy looking stuff that like is made in between the glans penis and the foreskin, just to kind of, I mean, I guess it's God's lubrication, I don't know, but that's smegma. I mean, it's one of the funnest words to say, you'll get used to it. So that's normal. So you don't want to confuse that with like candida. So smegma will move around. I mean, it's just freely mobile in there, whereas candida will be kind of stuck to the skin. It'll look red and angry. What did you say?
She choked on her drink.
Cookie, when you just said it moves, freely moves around.
It's freely mobile. Whereas candida or yeast will be kind of stuck to the skin and it'll be red and angry looking. So, if there is difficulty retracting it, that's, like I said, pathologic, that's phimosis. And then what you're seeing in the picture here is a paraphimosis. That's where the foreskin has been retracted and then you're unable to put it back because it's swollen and angry and inflamed. So again, circumcised versus uncircumcised. So if you're looking at that, you're not going to be able to examine it unless you pull back the hood, the cloak, right? So you got to do it. Pull it back and look around. So when you look at the glands, you do want to look around the meatus, the urethral meatus. Especially if somebody's coming in with discharge. Are we going to do STDs and infectious disease?
Mm-hmm.
Okay.
Well, last year it was supposed to be covered in OB-GYN, so it depends on if you don't cover it there, then I'll cover it in infectious disease.
Okay. So if somebody's coming in with penile discharge, that's their complaint, the drip, they're going to come in with complaints of that, then you need to get in there and look at it, and you need to try to express some out, see if you get discharge out from the meatus. So balanitis is inflammation of the glands. Men who are uncircumcised get balanitis. Circumcised men don't get that. Obviously, you're looking for lesions, right? The other thing with the meatus, you want to note where it's positioned, because there's actual congenital deformity related to where the meatus exits the shaft of the penis. So it should come out in the glands, but sometimes they don't. So you want to note that. Again, we're looking for lesions. This is herpes. And that's kind of the tricky thing about herpes is traditionally it'll be like vesicular, like blistery spots, but when I've ever seen it, it's looked more like that. More like aphis ulcers because the vesicles have popped. But it looks like it hurts. And they walk Nikki had one in the clinic.
I had a poor girl walking in the clinic just like that. So if you're ever on rotations and you see a young female coming in looking like she rode a horse for like days, and she's in pain, it's most likely herpes infection.
The other thing with documenting where the lesions are on the penis, you need to note anatomically, and you probably remember this from anatomy, what the dorsal surface is versus the ventral surface. So the dorsal surface is actually on top, which to me is like anterior, but it's where the penis is more erect. So the dorsal surface is closer to the patient. The ventral's on the outside, as the picture shows. This is just a picture of anatomy for you guys to look at as you're reviewing these slides. Because there are, you kind of need to know the basics of the anatomy to know where these pathological scroll masses and things, where they originate from. So the pampiniform plexus, where the veins are in the scrotum and the testicle, those, if they're dilated, they're called varicocele. You need to know the tunica vaginalis, that's where all the scrotal swelling usually tends to form, and we'll look at that closer here. And then you need to note where the superficial inguinal ring is, because that's where you need to get your finger all the way up to if you're examining for a hernia. Okay? I don't know where the stick is. Where's the stick?
And what you do want
And
to
you might need a stick this long.
once you do that, you'll know, you can feel where you go up, you know, like, you'll know you're not in the right spot if you can't advance it up.
You're gonna
towards that.
start your finger about there, and you're gonna smash it all the way in until
Yeah.
you get about there.
And it'll go there. If you're in the right spot, it'll go there. It'll go there.
Okay, so on to stage 2, scrotum and its contents. So, one thing to note on the gross anatomy is that it is normal for one to hang lower than the other. That's not necessarily abnormal. The left spermatic cord is longer, so often the left one will hang a little lower than the right. So an asymmetric hang is okay. They can be slightly asymmetric, but for them to look dramatically asymmetric is not normal. So we'll look at some pictures. Again, don't forget to lift it up and look on the back side. There are normal sebaceous cysts that men can develop on the scrotal sac itself, which are completely normal. They should not be large, swollen, and definitely shouldn't be erythematous, but it's normal for them to be wrinkled. And as they get older, things hang lower, you'll find. So proper technique for examining the scrotum and its contents are you do want to use 2 hands. You'll want to kind of support the scrotum as you kind of feel with the other hand. You want to make sure first and foremost that there's 2 testicles present in each side. If there aren't, you need to go looking for them. When you're examining the scrotum as well, if you're laying the patient on their back is not the best place. We talked about this earlier. It's not the best place. You're going to see more abnormalities with them standing. So, a varicocele is basically dilated veins. It pretty much just varicosities. They're more common on the left side than the right. So it honestly feels like a bag of worms. Have you felt a varicosity before? It feels like it's exactly that. There's no better way to describe it. It's like a bag of worms. So you need to just kind of know the anatomy of the testicle. It's oblong shaped. The epididymis should sit posterior to it. It's kind of egg or oblong shaped. The spermatic cord you'll want to palpate. When you palpate the spermatic cord, you want to kind of do that simultaneously with both hands. Just kind of get an idea of so you can compare one side to the other. So when you're examining the testicle, it should be freely mobile from the scrotum itself. It shouldn't feel stuck to it. It shouldn't be hard. It should kind of be rubbery. So if you're feeling a testicle and it feels like a rock, that patient has testicular cancer until proven otherwise. So testes should not feel hard and rock-like at all. They should be smooth, rubbery, about the consistency of like a pencil eraser kind of. You do want to compare bilaterally that they're about equal size. The epididymis again should be kind of posterior on the testis itself. You'll be able to feel that it kind of sits on the outside of the testicle. And then there's a picture of the spermatic cord where you kind of want to compare those. You can palpate those simultaneously. And if you have a scrotal mass that you need to further evaluate, then you need to transilluminate it. Dim the lights with a chaperone. A cool light source, so a pen light or, something that doesn't heat up, just to be kind to your patient. You'll want to just kind of shine it from the back and see if the light is able to penetrate through the mass. Obviously, if the light can't penetrate it, that mass is solid. If the light shines through, it's a cystic or fluid-filled mass, so fancy, super high tech. I gave you guys a chart on this. I added a couple extra things to it. It just kind of helps you clinically break down how you should think about scrotal swelling when you're evaluating someone. The biggest thing is that they come in with pain or no pain. If they came in with pain, it's gonna, your list of differentials are gonna go one way. If it's a painless mass, it's gonna go the other way. So just kind of help you delineate that. If you have somebody come in with scrotal swelling, you need to first determine whether if it's solid or fluid, where the swelling is located. Is it kind of in the front? Is it in the back? Spermatoceles originate on the epididymis, so they'll kind of be in the back. Hydrocele are going to be right out in front, big swelling. And those, honestly, y'all should Google it and Google a video of somebody draining a hydrocele. It's just like they just put a needle in there and just let it drain. Spermatoceles will be more of kind of a milky fluid. Hydroceles will be completely serous. Epididymitis are going to come in with pain. Testicular torsion are going to come in with pain. Orchitis are going to come in with pain. Varicoceles, they may or may not have pain. They may feel kind of heaviness or fullness on the left testicle. They may come in not being able to get their wife pregnant, because varicoceles can actually contribute to male infertility. Hematoceles are blood in the tunica vaginalis. So the tunica vaginalis has like a visceral and a parietal layer, just like you would have in the lungs, just so things can move and slide in there and not have a lot of friction. So that's the space in which the fluid fills. So if it's traumatic, they had some type of traumatic injury, then it's probably a hematocele, and you can tell that with transillumination. It'll look more opaque. It won't transilluminate very well because it's blood rather than serous fluid. And then it's always bad when you have a male in the range of 15 to 30 years old with a painless testicular mass that doesn't transilluminate. That's going to be that's testicular cancer until proven otherwise. So again, torsion, testicular torsion, which you'll get this in a lecture, Professor Brooks, so they have a specific lecture on the testicle.
Yeah, there's a urologist coming to speak to them.
Yeah. So as far as from physical exam, these patients are going to be in a lot of pain. I think I put on your chart, they might have that same side on that leg kind of flexed, kind of protected. The testicles sit higher on that side because it's twisted and pulled up. It's going to be younger males. Orchitis, there's probably going to be some other type of infection or going on. It's textbook is going to be the mumps that gives boys orchitis. And then, again, testicular tumors are the ones you don't want to miss. So it can be somewhat confusing in the emergency room trying to figure out, because both epididymitis and testicular torsion will come in with pain. Why does my ball hurt, you know? So if there's other signs of infection, that's probably epididymitis. If it kind of came on a little bit more gradual over a day or two, probably epididymitis. If it came on like a light switch, like all of a sudden excruciating pain, that's probably torsion. Vomiting. So, I mean, the guy with testicular torsion is really sick. You know, you hear us talk about, did they look real sick? Were they ill appearing? That's one of the patients that's gonna come in, and he's gonna go through triage pretty quick, but these guys, but patients also know how to get back quick too. So then if I can have the complaints of testicular torsion, I'll get back and get my morphine quicker too. So you need to know kind of how to figure out clinically if it's legit or not. They will not have fever with torsion. They will not have dysuria with torsion. But it looks ugly when they have torsion. Just really, it looks like it hurts. Inflamed, they're gonna be pretty young, maybe probably adolescent to maybe early 20s. Does everybody know how torsion happens? Basically, the testicle just turns on its spermatic cord, and it just kind of flips on itself. And the reason it gets so swollen and painful is it's causing ischemia, because the vessels just get occluded from the twisting. So, any questions about penis or scrotum? No? No?
Very thorough.
Well, they were telling the story today during the faculty meeting about Professor Hughes. And she was a student trying to do a swab, because you used to have to swab for gonorrhea and chlamydia. She was a student, and so don't do this. Don't go in with a swab and go chase the penis all around the table trying to get the swab in. Just grab it, put the swab. She's like, I can't get the swab. And it was Dr. McNeil, I think, wasn't it? He's like, well, how are you doing it? And he said literally shoot. Use the other hand, hold it still.
She never let that story down. So she graduated probably 20 years ago.
Yeah,
Still
still tell
that story.
So again, hernias, okay? This picture shows somebody using the pinky, probably because it's a child. So if it's a little kid, use your pinky. If an adult, you're going to use your index finger. But you're basically going to start anterior and just kind of slide that floppy skin up there and just go right up into the inguinal ring. And you should be able to feel it because it's kind of oval shaped. You may kind of get up in there and already feel it as you get towards the ring. But if you don't feel anything, you feel like, okay, the testicle's there, so you go up there and you don't feel anything, then have your patient cough. And if the cough, you get a little tap and the patient coughs, then that's what kind of hernia. It's coming indirect, it's going in the canal. Well, and most of the time with direct hernias, you'll just see them when you stand them up. Stand them up, and you may not even have to put your hand in there, just have them bear down like they're having a bowel movement, just Valsalva. And the direct hernia, you may just see it bulge out. But if you feel a tap, not on the tip of your finger, if you feel a tap medial, that's also a direct hernia, which you can see here. So if you kind of trace your finger all the way up there and you get it up, all the way up in the ring, and then you have the patient bear down and it taps on the medial side towards more midline, and that's a direct hernia as well. But you can get, with an indirect hernia, the loop of bowel can come all the way down into the sac. So that's why sometimes it's difficult to differentiate between a strangulated indirect hernia or a testicular torsion, because they're both causing ischemia, they're both causing severe pain. You're going to get an urgent ultrasound on that person. So indirect and direct hernias can kind of, sometimes you're looking at a test question, you're like, I can't remember which was which, but if you'll just remember that direct hernias come directly out from the abdominal wall. Like they don't have to take a pathway, they just bulge out. So they come directly out. Indirect has to take the path of least resistance, so it goes through the canal. And what age group will also kind of help you determine. If it's an older patient, it's probably a direct hernia. If it's a younger patient, it's probably indirect. This is just another good picture of it. All right, y'all ready for some videos? Okay, let's see if it works. I don't know what button I'm supposed to hit.
Exit out, ladies.
Escape.
Press escape. And then press escape on the keyboard.
Pop one.
There's not a way to make it play within the PowerPoint.
Well, you might have, need to enable
Did you add the link in there? You have to insert the link to
I
the
did, I
slide.
embedded the link.
And the show, and the show, and the show.
I don't,
Enable.
I know how to do it by ending the show. And I enable editing.
Yeah, and then you have to enable the content. Should work. It's gone.
See, this is what annoys me.
Because sometimes, like, you could say, can you guys sit in your PowerPoint?
I've never been.
You never let us live it.
I embed it in the thing, and it has never worked. Once. So what we'll do,
You might have to open it up under these well.
that's what I thought, that's always what I do. Has anybody watched these yet?
We're now going to do the male genital exam as well as the inguinal hernia exam in this position. So the exam in the genitalia, we're doing primarily inspection but also palpation. We want to inspect the penis. If the patient is not circumcised, be sure to retract the foreskin. The glans penis, the urethral meatus, the position on the penis is important. And then we're going to examine the scrotum and the scrotal contents. Remember, the testes are bilateral. They'll be at slightly different elevations. That's normal. The testis has the epididymis. It should lie posteriorly. So when you're examining, the epididymis should be on the posterior side. And then we'll feel up gently up the spermatic cord. And then into the external inguinal ring to check for hernias. If you find masses in the scrotum, it's useful to transilluminate those to see if they're fluid-filled or solid. I will not demonstrate that today. So, first thing is to glove up. Remember that patients can be anxious about this exam and uncomfortable. It takes a little practice to keep yourself comfortable. So I tend to chat my way through the exam so that the patient is not thinking too much about it. Let's just hold this up a little bit. Good. So examine the penis, the glands, urethral meatus, normal. Remember, the skin of the scrotum is very thin and very sensitive, very gentle with the testes. They're oblong. I can feel the epididymis posteriorly. It should be very mobile within the scrotum. Okay, normal. And then to look for hernias, we're going to take some slack skin from the scrotum. We're going to advance my fingertip up to the external ring. Have you turn your head to the left and cough hard. Good. And if there's a hernia, you'll feel it come down and tap the end of your finger, and again, on the opposite side, right into the external ring, cough. Good, all right. And that really completes the male genital exam. Inspection, palpation of the testes, and palpation for any hernias at the external ring.
And your patients don't have to stand
Probably makes it
Professor Rhodes, were you listening to Rick and Brad this morning?
Yes.
Did you hear the horse race? They were playing a playback of the horse races here at Remington Park from Friday night, and one of the horses' names was D's Nuts. Yes. So the announcer, it's like, it was Cage Fighter versus D's Nuts. It was great. Why, I mean, people intentionally name their horses that just so somebody will have to say that. Let's go back to, okay, so what you'll see in the video here in a minute is he's just going to turn him around and do the prostate exam, but first we'll talk about it. This poor guy. But the practitioner's being nice. He's got some lubrication here. He's going to be kind with the hind. So, and it's okay to just show the patient, say, you know, I just want you to put your hands like this. You know, just kind of, it's okay. With Professor Brooks, isn't there an SP that likes them to show them how to?
Yes. The SPs, like I said, they will not be shy on Wednesday. So some of them may even direct your hand on where to move it to actually get a good feel of his prostate. Because they know, they can tell when you're touching their prostate. So they may move you, I mean, like I said, they're not shy at all. They want you guys to learn and feel what you need to be feeling for, so.
So the first thing you're looking for, don't forget when you're doing a prostate exam to look at the skin. You guys have, you know what hemorrhoids are, right? You've seen pictures of hemorrhoids, you've seen pictures of fistulas, you've seen pictures of fissures. Now you get to learn what condyloma acuminata looks like, which is genital warts. Candidiasis, which won't be that uncommon. You'll see basically jock itch, but of the butt crack. It's pretty common in diabetic men, especially in the summertime. They're hot and sweaty. And then you need to just know what a skin tag looks like. So you see something that looks like that, skin tag, that is not a cancer, don't be worried about it. That's just where an old external hemorrhoid was, and the hemorrhoid's gone and you're just left with a tag of skin there. So it's nice for you to tell your patient what you're going to do before you do it. Okay? Say this should not hurt. It's not going to take very long. You want to insert your finger just maybe to the DIP joint just to get them to not clamp down, just to get them to relax. And then go ahead and put the rest of your finger in. The rectum will relax because that's how you poop, right? You have to relax your external sphincter to let the bowel movement out. So if the patient will just relax, it will happen and it won't hurt them. The prostate is, so when you feel it, you're going to feel down. So that's why in GI, when you're examining the rectum for cancer or for blood or for abnormalities, you're laying them left lateral to cubitus. But if you're doing a prostate exam, it's much better anatomically for you to have them bent over because the prostate's just right there if they're bending over the table. And as you can see from the diagram, you don't have to go very far at all to feel the entire prostate. So
It's just gonna be right inside.
And if you have them laying or bent over, it's just gonna be quick to get there. When you're feeling it, you're gonna feel, is there tenderness? Is it enlarged, which you're not gonna know until you feel a bunch of prostates, whether you're just gonna have to kind of figure it out, because, well, I don't know, is this enlarged or not? So, feeling a normal one this week is good, because then at least you've felt one normal prostate. I'm not an expert at feeling prostates. I mean, I felt a bunch of them because I worked in GI and did a bunch of rectal exams, but I have not ever felt a prostate cancer. And I've been a PA for 13 years. So it's just, if you get into the field of urology, you're gonna be really good at feeling abnormal prostates. But
And we did have problems, some of the girls last year had very short fingers, so a lot of times they just have really small hands, and so they can't reach that far up. I mean, that's just part of that. You may not be able to reach that far in unless you're able to really push further in without making the patient uncomfortable.
I don't have that problem. I can fall in the men's basketball. Yeah. So, yes,
Are you supposed to do this slowly or just, like, how fast do you recommend inserting your
Well,
finger into the rectum?
slowly. You don't want to make it painstakingly slow, but
I like slow-mo, not like slow-mo slow, but because you're wanting to feel the inside rim of the rectum for
Right.
the masses as well.
once you're in there, I mean, you gotta bury it, I mean, you gotta get pretty far in there. Then you do the sweep to the left, sweep to the right, and then you sweep the circumference. So you wanna feel both sides of the prostate. I envision the prostate of kind of being like a peach. It's kind of got a little butt on it. You know, like, I could be completely wrong, but I think of it having like the one side and the other side, and then sweep the rectum.
It's either like a thyroid, you have a left lobe and a right lobe with the thyroid and you have the middle.
I've never dissected the prostate, but that's how I just look at it. You grade prostatic enlargement on a scale of 1 to 4. So, and you're not gonna be grading prostates in unless you're in urology, because in general medicine now, the prostate exam is not recommended as a screening tool anymore for prostate cancer. It's more harm than good. So, you're gonna be examining prostates in men that have complaints. So if they're coming in with urinary frequency, hesitancy, nocturia, you're gonna examine the prostate. If they have perineal pain, you know, if you're worried about prostatitis, dysuria, things like that, you're gonna check it. But gone is the time where every man, after the age of 50, got a prostate exam every year. That's not the recommendation anymore. Aerial view, anyone? Again, it's just kind of showing you should just feel left and feel right. If you feel that, that's a rectal cancer. So again, don't forget that when you're examining a prostate, you could catch a colon cancer too. Polyps are kind of that little rounded bulge, and that's gonna be tiny. It looks super zoomed in. Because this is a picture on a colonoscopy, but you'll just feel a little bit of a bump. The other thing is hemorrhoids are gonna be right inside. I mean, hemorrhoids, internal hemorrhoids are gonna be right inside the anal canal. But if you're in examining a prostate and you feel a bump, that's not a hemorrhoid. So they need to go get a colonoscopy if that's the case. So that's where it's important to don't just feel the prostate and then pull out. Feel the prostate and then kind of circle around and feel the rectum. Okay. make a quick loop, and then pull out. And just think of it, that it may be the only time that man ever gets anything close to a colorectal screening test. So if you're checking their prostate, it's also a good opportunity to do a quick colorectal cancer screen. And get a hemocol if you're there. Doesn't take much. I think we talked about this in GI. Just a tiny little smear of stool. And I have done a lot of rectal exams, and don't, please, you guys, don't think that you're gonna pull your finger out and it's gonna be like covered in poo. It's not. I don't know how many rectal exams I've done. That's never happened. So people who need to poop immediately have, or people who are impacted have stool in their rectum. But if that patient has gone to the bathroom already that day, there's not going to be a bunch of stool in the rectum. So. Now you guys are going to get lectures on what BPH is, so I'm not going to cover this in much detail. So BPH, benign prostatic hypertrophy, is going to feel like an enlarged prostate. It's not necessarily going to feel hard or nodular, irregular. If you stick your finger in, it feels like you're rubbing over gravel or a rock, that's cancer. And then again, prostatitis is going to be uncomfortable for them. Don't massage a prostate that you think might be infected. You can actually see the infection, give them septicemia. So no prostate massages when people have prostatitis.
Could you massage it at any other?
No.
I mean.
Don't. We should be massaging prostates, but just be careful not to be like, oh yeah, I don't know. So feel enlarged, just don't keep palpating around if you think it might be infected. All right, and this poor man is going to get his prostate checked now. So once you have finished the genitalia exam, it's real easy just to turn them around.
We're now going to do the rectal examination. I do this as a continuation of my genital examination. So first thing I'm going to do is get gloved. It's important to try to keep the patient comfortable. Nobody enjoys these exams. But it's important for you to be comfortable in order for the patient to be comfortable. Always tell the patient exactly what you're going to do so that they're not surprised because that will elicit, obviously, inappropriate contraction of the muscle. So first thing I'll have the patient just remove his shorts. Okay. Now, when we do the rectal examination, we're first of all going to inspect between the gluteal folds. Look at the anus. I'm going to check for an anal wink. An anal wink is a cutaneous reflex elicited by just tapping the skin, the perianal skin, and seeing reflex contraction of the anus. And then we'll go ahead and do the rectal examination. It's important when you do a rectal examination to introduce your finger very gently, lubricate the finger well, put the lubricated fingertip right on the anal opening, very gentle pressure, and ask the patient to push down gently. That helps relax the external sphincter, the voluntary sphincter. That's what we do when we have a bowel movement. So when we feel a little pressure there, and then the sphincter will relax and you can advance the finger slowly into the rectum. Remember, you want to advance straight in and then palpate the structures, the prostate and min, which is on the anterior rectal wall, and then be sure to sweep the rectal vault all the way around looking for any masses. So it's important to position the patient in a comfortable way. I find that having the patient bend over the exam table is very efficient. It helps them relax. They can put their weight on the exam table. And it also makes it a little more difficult for them to jump or move away from you. So we have him bend down gently, supporting the weight, feet a little ways apart. The first thing we're going to do is just inspect and then check that anal wink. We do that just examining the gluteal cleft, exposing the anus, and just tapping and seeing that anal wink. Then we lubricate the finger. Make sure it's well lubricated. Place the finger gently on the anus and have the patient push down gently. Slowly push the finger in. Good. And now we're just going to feel the prostate. Feel all the way around the circumference of the rectum and gently remove your finger. And that completes the rectal examination. Nobody enjoys rectal examinations, but it's a very important skill to get yourself comfortable with. Many lesions can only be identified with a good rectal examination.
Wipe the jelly off their butt. I mean, that's just the nice way. Have some 4x4s there, and don't send them home with KY running down their floors. That's just the polite thing to do. Okay, so the other part of Wednesday is going to be catheters. Anyone placed a Foley catheter before? I forgot we can use you guys to help demo too, but my sister's an RN and she's bringing another RN from the ER, so they'll be there more hands on deck for demo and things like that. So we're going to watch a quick video on the Foley catheter. Gives you a little bit more anatomy on why we do what we do. And you guys can watch. There's several videos y'all can watch later. And then after this, we're done. So if anybody needs to take a quick 5 break.
This is a video in clinical medicine from the New England Journal of Medicine.
Therapeutically, catheters may be placed to decompress the bladder in patients with acute or chronic urinary retention. In addition, catheters may be placed to facilitate bladder irrigation in patients with gross hematuria. Diagnostically, urinary catheters may be placed to obtain an uncontaminated urine sample for microbiologic testing, to measure urinary output in critically ill patients or during surgical procedures, or to measure post-void residuals. The only absolute contraindication to urethral catheterization is known or suspected urethral injury, usually in the setting of a pelvic fracture. Trauma patients presenting with blood at the urethral meatus or with gross hematuria, perineal hematoma, or a high-riding prostate gland should be evaluated with retrograde urethropography before catheterization. Relative contraindications to catheterization include urethral stricture, recent urethral or bladder surgery, and a combative or uncooperative patient. Most of the equipment required for urinary catheterization can often be found in a prepackaged catheterization tray. The contents of a typical tray include sterile drapes and gloves, an antiseptic solution such as povidone, iodine, or chlorhexidine, and cotton balls and forceps for application of antiseptic. Kits also include a Foley catheter, a sterile lubricant, a syringe with water for balloon inflation, and a sterile drainage bag. Additional equipment that is not included in the standard tray includes viscous lidocaine and tape or another device to secure the catheter to the patient. There are many different types and sizes of urinary catheters available. The Foley catheter, a double-lumen urethral catheter with a straight tip, is most frequently used. One lumen is dedicated to urinary drainage, and the second is used to inflate the retention balloon at the distal end of the catheter. A 16 to 18 French is the appropriate size for most adult patients. Larger catheters, 22 to 24 French, should be used for patients with gross hematuria in order to prevent clots from obstructing the lumen. The Coudet catheter, has a semi-rigid, curved tip that facilitates catheterization in men with prostatic enlargement. Triple lumen catheters, which have an additional port for bladder irrigation, are often used in patients with gross hematuria or clots. The average male urethra is approximately 20 centimeters long and takes an S-shaped course through the penis, urogenital diaphragm, and prostate gland. Note that downward traction on the penis exaggerates this curvature, making catheterization difficult. When the penis is held taut and perpendicular to the body, the urethra straightens, facilitating the procedure. Carefully inspect and prepare all equipment before beginning the catheterization. Sterile gloves should be worn when equipment is handled and while the procedure is carried out. Arrange the contents of the catheterization tray on a bedside table. Check the integrity of the retention balloon and securely attach the catheter to the collection tubing on the drainage bag. Finally, pour the antiseptic solution onto the cotton balls and lubricate the distal tip of the catheter. Place the patient in a supine position on the stretcher. The foreskin should be fully retracted in uncircumcised patients. Next, inject 10 to 15 milliliters of viscous lidocaine into the urethra. This not only anesthetizes the mucosa, but also distends the urethra, facilitating catheterization. Firmly pinch the end of the penis for several minutes to retain the lidocaine within the urethra. Place the sterile drape over the patient's thighs and the fenestrated drape over the pubic region. Grasp the shaft of the penis with your non-dominant hand. This hand is now considered to be non-sterile, and it should not let go of the penis or touch any sterile equipment throughout the remainder of the procedure. Cleanse the glands in a circular motion using the forceps and antiseptic-soaked cotton balls. It is helpful to place the box from the catheter kit on the patient's thighs before the catheter is placed. During insertion, the penis is held upright, perpendicular to the plane of the body. In this demonstration, a coude catheter is being used. When using a coude, be sure that the tip of the curved catheter is pointing upward in the 12 o'clock position. Place the tip of the catheter into the meatus and advance it slowly and gently through the urethra. Never force the catheter, since this may create a false passage or other urethral trauma. Continue to hold the penis upright to straighten the penile urethra. Some resistance may be encountered as the catheter reaches the level of the external sphincter. Instruct the patient to breathe deeply to relax the sphincter. Apply slow continuous pressure to the catheter and advance the catheter to the level of the side channel. Before inflating the balloon, confirm proper placement by observing the flow of urine into the collecting tube. If no urine is returned, the catheter is probably obstructed by lubricating jelly and should be flushed with normal saline. Gentle palpation of the bladder may also promote urinary flow into the collecting system. Once proper placement is confirmed, inflate the retention balloon with 10 milliliters of water. Air or normal saline should not be used. It is important to inflate the balloon while the catheter is fully inserted to avoid inflation while the balloon is still in the urethra. Next, gently pull the catheter back to seat the retention balloon against the bladder wall. If the patient is uncircumcised, pull the foreskin back over the glands to prevent the development of a paraphimosis. Finally, secure the collection tubing to either the thigh or the anterior abdominal wall and hang the collection bag in a dependent position to prevent the reflux of drained urine back into the bladder. Catheterization may be difficult to perform in patients with prostatic enlargement. This is usually sensed as resistance to the advancement of the catheter at approximately 16 to 20 centimeters. Use of the coude catheter may alleviate this problem, since its firm, curved tip may traverse the exaggerated curve of the prostatic urethra. If a coude catheter is not available, a larger Foley catheter, size 20 to 24 French, may be used. Although counterintuitive, The use of the smaller catheter does not facilitate catheterization, since it is less firm than a larger catheter and is likely to kink at the neck of the bladder. Urology consultation should be obtained if you are unable to enter or advance through the urethra due to phimosis, meatal stenosis, or urethral stricture. The catheter should never be forcefully advanced, as this is unlikely to be successful and may result in urethral trauma. Urinary tract infections are common after urethral catheterization. Although many cases are limited to asymptomatic bacteriuria, significant illness or death may result. The single best way to avoid catheter-related infections is to avoid catheterization whenever possible. Additional complications of urethral catheterization include paraphimosis, trauma to the urethra and bladder, and non-deflation of the retention balloon.
Everybody ready to put a cath in now?
At least those will be on our simulation meeting.
Right, we're doing these on mannequins, not on rest. All right, any questions?
Do y'all have any questions for tomorrow? I mean, for the exam? No, for Wednesday, you all can dress casual. You don't need to, for this process exam. The test will be at 10.
Are you done? Or no, we're not yet.
Any questions? That's it, you have to know, Sarah? So, just remember, I know there's a question, I had gotten a question that was sent out about, the anti-GBM glomerulonephritis, so don't forget, that's the same as good pastures, except good pastures will involve the lung, right? So just remember that, they're the same thing, but just with lung involvement for good pastures. So just remember, kind of differentiate that way. What else is, differentiate that between, like what is that, polyangiitis, those kind of things. So just kind of look those up and kind of so you can differentiate between what those people would show on lab, lab values or biopsies, things like that. What, which nephropathy is most common in children.
Minimal change.
So just pick out those things, and then, so if I give you a set of lab values, you'll be able to read it and decide what's, if they have high protein in their urine, they are most likely nephritic or nephrotic. So then you will know by looking at that, then you kind of decide down what kind of casts are. Let's say if I gave you a muddy cast, what would it be? So those are kind of things what I want you guys to do whenever you start, while you're studying, is in your mind, say if I give you, what you can delineate if it's a nephritic versus a nephrotic patient, then you can just kind of go down from there. Does that make sense? You study, so that helps you from being overwhelmed by looking at all the data at one time. Okay? Good luck studying.
Bye guys.